This is SG2 Perspectives, a conversation with industry experts and SG2 thought leaders about the biggest trends in healthcare and what we all expect that's going to mean for the future of healthcare delivery.
The overall inpatient forecast for procedures is going to be declining by about 1% over the next decade. So that ongoing inpatient-outpatient shift is going to be not seen for tertiary procedures that are the bread and butter of AMCs. But we're seeing a really strong and rosy picture for the continued procedural activity at AMCs.
Hello and welcome to SG2 Perspectives. I'm your host, Trevor Dorin, and with me today are two outstanding colleagues, Tawnya Bosko making her first appearance on this podcast. Along with her is Justin Cassidy, an old pro at podcasting. He's been on a few episodes recently. I asked them to discuss the unique role that academic medical centers have played in the response to COVID-19 and really some of the new trends emerging from AMCs that could reshape their role in the healthcare system of the future that we're all kind of defining as we go here. Every hospital had a relatively similar spring and early summer in that they had to be totally prepared for COVID patients at the same time stopping elective surgeries. But did AMCs play a unique role during that time?
The answer is yes, absolutely. And you are correct in saying that everyone had a difficult time as electives were shut down. AMCs were no different in that that was really a struggle that all health systems had to deal with. With that tripartite mission, and you think about what an academic medical center represents, they really had to focus in on the research and innovation side at the same time as dealing with the health delivery challenges. So their communities were looking to them to understand this disease as COVID-19 spread and to give some reassurance about where we were going, how we were going to treat this, and that we were all going to get through this. And even more of a public health role, a lot of our academic medical centers were playing as we got through the pandemic. And you look to examples like Johns Hopkins, where I think we're all looking at their dashboard now to understand the spread of the disease and the fatalities from the disease. So definitely our academic medical centers played a very unique role, and it may change how they interact with public health as we move forward.
We can sum it up in one sentence, really, that AMCs have changed in that their care has gotten a lot more local. Thinking about the topic today, destination medicine in a state where we're in many shelter-in-place orders, travel was shuttered during March, April of this year. Many AMCs thought that they would no longer receive those destination travel admissions that really are critical to their bottom line. As we think about surgical cross-subsidization being essential for the clinical enterprise of the AMC mission. That national, international destination travel has been changed to regional. And as we know, health systems have been getting bigger, including AMCs, and that expansion of ambulatory footprint, the expanded geography and catchment of patients has pulled more folks into this AMCs in particular that might be faced with health inequities amidst the COVID-19 epidemic. And that's been a struggle, but also clearly serving a critical need in the community. And what's really optimistic is that as we've seen that clinical innovation that you described, Tawnya, that the recovery to AMCs has returned amidst clinical innovation, keeping folks out of the hospital. We're not clear to whether or not some of that recovery is just serving a backlog or true surgical recovery. And many AMCs are reporting that folks are not scheduling their procedures as far out as they used to. And that'll be kind of the litmus test in confidence as we move forward.
Thanks for adding that, Justin. How did AMC's role maybe change a little bit during the summer surge? We got a little bit better at treatment, less patients needed ICU level care, but we've also seen research that there was different outcomes for patients that were in really large hospitals with ICUs with more than 50 beds. Did AMC's role kind of continue to evolve over the summer as we treated the disease a little bit differently?
It certainly did, Trevor. And what has happened is a recovery of tertiary procedures. So these are procedures that are, by definition, more medically complex. At SG2, we define them as those that the DRGs are about 95% or more discharge volumes at academic medical centers, or that there's a significant proportion of those DRGs at an academic medical center, but it has a high CMI or case mix index. Those tertiary procedures recovered fast, even this summer. And as SG2 is forecasting out over the next decade, in terms of inpatient tertiary procedures, we're going to be seeing a 15% increase. And that's above and beyond population alone based forecast. And to put this into context, the overall inpatient forecast for procedures is going to be declining by about 1% over the next decade. So that ongoing inpatient-outpatient shift is going to be not seen for tertiary procedures that are the bread and butter of AMCs. The story is different per procedure, but thinking about what those tertiary procedures are, it's things like transplants, bone marrow transplants, complex thoracic surgery like lobectomy and pneumonectomy, transcatheter valve procedures, endovascular procedures, and so on. Those are going to be really increasing over the next decade. And other procedures might be a little bit less strong to continued growth, but we're seeing a really strong and rosy picture for the continued procedural activity at AMCs.
And Justin, I think one of the other ways AMCs kind of changed and morphed as we went into the summer months with that second surge was also to think about recovery and reinforcing to patients that it's safe to come back. I know we've seen a lot of partnerships with airlines, with Clorox and other cleaning companies, with our prominent academic medical centers in really trying to make sure we have that reassurance for patients in coming back to the institution. That's pretty innovative faced with the pandemic to really go down the road of these strategic partnerships to make sure our patients are safe in coming back.
Yeah, some of that seems like a temporary shift. Is that the way you see it? COVID's been an accelerator of a lot of the changes that were already happening across the industry. Are some of those things you talked about changes, or is the pendulum going to swing back here in the next few months?
Despite the very innovative partnerships with the airlines, we're still seeing a reluctance of people to want to get on planes for healthcare services. While a lot of our prominent AMCs have been the beneficiaries of the destination care, people traveling great distances to receive the care, particularly in oncology and some of our other key service lines, I think that's changed more of a regional pool now. So think areas where patients can drive to the academic medical center to receive care. And we verified this. Justin and I have both talked with multiple academic medical centers that have said, yes, they definitely are getting those patients back in terms of destination patients, but they're coming from not as far away. So you're definitely seeing more of that regional pool versus a more national pool. We do think that that will change in that people will start to travel again eventually, but I don't think we can say for sure yet when that will be. You also have to consider that it could change some of the patterns for these services that maybe historically people were willing to travel for. They realize that there could be another provider within their region where it makes sense to go for care.
This is really where that safe care comes into play as you kind of renovate your ambulatory environment to make it more clean and friendly for sort of mobile or drive-through types of visits. That's very essential for pre-procedural activities, as is the shift to virtual health for those pre-surgical consults. Absolutely critical. And the other real key piece to note here is the fact that the top traveled for inpatient procedure is actually no procedure. As Tawnya, myself, and colleagues have undergone destination analytic analysis, it was really shocking to see that 37% of all the top traveled for inpatient activity is for no procedure. And the top service line is actually for medicine. And that includes things like UTIs, poisonings, pancreatic disease, sepsis, pneumonia, and COPD. So stuff that could be served potentially via a telehealth or virtual sort of consult. And we have a great example of this that we've been developing with Johns Hopkins and their division of rheumatology. They're number one ranked program in rheumatology nationwide. And they basically have coordinated a destination center for this service and actually integrated an interesting digital platform sort of strategy. They have something called Room TV that is essentially over 100 disease education videos available for free to anyone. So you can just log online. If you're interested in rheumatology, think you might have something wrong, might have questions about something, you can go and check that consultation out before making an actual consultation. This sort of visit can be facilitated virtually, as can those pre and post-surgical visits, and absolutely essential to think about wraparounding your destination visit.
Yeah, so I know there's more to say about some of these new creative digital models, but my understanding is historically, most destination care has been driven by physician referrals. Is that shifting?
I don't know that it's necessarily shifting from the pandemic. Over time, we're seeing more of that consumerism effect in destination care, much like we are other areas of healthcare. So definitely some shift from that. I wouldn't necessarily tie that piece directly to the pandemic. However, what has changed as a result of the pandemic and people's unwillingness to travel are virtual second opinions. The demand for virtual second opinions, whether physician-referred or patient-directed, has increased sharply as we've worked through COVID-19. Justin and I have talked about this multiple times. There are organizations that have been doing this for a long time. So think Cleveland Clinic, for example, has a very robust virtual second opinion program, as do some others. But there are a lot of our major world-renowned academic medical centers that haven't had virtual second opinions in place. And so now we're seeing some of those organizations scramble to get that set up to capture some of this demand for those services.
Tawnya, that's a great point on the virtual second opinions. And Stanford Medicine has one, for instance, as well. They're cash pay and often out of pocket, but can be paid with health savings accounts or flexible spending accounts. So really kind of interesting. It's not just for very traveled for procedures like cancer. It can also be for other types of surgical services. Rush University, for instance, has a really successful thoracic surgery virtual second opinion program. Patient cash pay, there is some degree of uncertainty as to whether or not the relaxed guidelines in terms of medical practice across state lines are going to kind of impinge upon the expansion of these sorts of services, or if those sorts of changes will be retained after the pandemic state of emergency. So that's certainly something to watch from the regulatory side. In terms of that upstream referral, and Tawnya, you've told me this many times in doing your analyses, over 80% of patients still rely on advice from their physician in terms of that upstream referral. So that is absolutely critical to maintain. That's going to be your bread and butter. Absolutely. Number two is also about those 20% of patients that self-refer. And they could self-refer for a variety of reasons. Individually educated. They might have friends or family in healthcare that are telling them to go to one center versus another, just from personal experience. It also might be that individuals are doing their own research on the front end. And now with so many of us using our cell phones as sort of portals to the world, the first thing that we do when we have a question is Google it. And even pre-pandemic, 6 in 10 patients would actually attempt to diagnose themselves using Dr. Google, just browsing symptoms on the internet before the pandemic. This is something that is more prevalent than ever. Before pandemic, it was across generational divide. So millennials were almost 80% doing this sort of self-diagnosis upstream and trying to determine where to go for care. Baby boomers were about 50%. But now we think that there's been a catalysis of that sort of shift to even upstream of that physician referral. To get that first physician referral, you still have to do these sorts of online searches. And that could be an essential part of your marketing strategy in the years to come.
Say more about that. I'm sure AMCs are in some ways using this as a little bit of a kick in the behind to change and really accelerate the development of their digital platform to reach patients in new ways.
Gosh, yes. The digital platform is big across the board for the reasons amidst the pandemic that we described prior. Tawnya mentioned that Johns Hopkins COVID-19 case tracker and really free advertisement and brand awareness throughout the pandemic as you saw the case numbers slowly tick up on the upper right-hand screen of every news channel you've been watching amidst the pandemic, and still see this from time to time in terms of reference. It's just clearly not associated with the clinical enterprise, more on the research, but certainly is raising the brand awareness of Hopkins. There are others as well, though. They're a little bit less well known. University of Maryland has a COVID-19 impact analysis platform, and this is really tracking the complex interplay between social issues and mobility within populations to help drive local policy decision-making. Are patients actually in your community very mobile? Because that might affect community spread. And then finally, thinking about just in need, a nimbleness can be served by these digital platforms. A great example is UCSF's online street medic training amidst the protests in response to health inequities this summer. This was really an informal training that was offered for an hour, but drew almost 6,000 people for this sort of life support skills. Serving that just-in-time need can really help draw more patients into your program, get them more aware of all of the great research that your institution is doing and how that can facilitate safe care moving forward.
So Tawnya, if you don't mind, put a bow on some of these things. We talked about shifting travel patterns, a new role for AMCs, changes in our forecast for some of the services that have traditionally been kind of the bread and butter of what we think of for AMCs, and of course, the growth of the digital platform. Summarize some of those thoughts for us in a relatively clean package.
Where we started out was AMCs, like the rest of our health systems, struggled through COVID-19 with the reduction in electives. However, as we've said historically, AMCs have been well positioned because of tertiary quaternary services. We still expect very strong growth, whether to capture those volumes locally within your community, which obviously that's your primary market to pull from, or from broader areas will be determined as we we move forward and determine people's reluctance or not to travel? How soon do we have a vaccine for COVID-19? And are people more willing to get back on planes to travel for care? And not just domestically, but internationally as well. In the meantime, capturing that share within the region, within driving distance, making sure that we have the physician and other health system partnerships in place to be able to capture that share will be key. It's almost like shifting gears to a different market area focus, where historically it had been more broad, but not moving your sights off of that broad perspective either, because we know that eventually we will get through COVID-19. I think the other piece that Justin just commented on in terms of digital platforms, that also ties back to some of the steps that organizations have taken from a marketing and brand perspective. So digital platforms, partnerships with the airlines and other companies, those things all help to build the brand of the AMC. So whether patients are traveling shorter distances or eventually longer distances, again, it's still helping to build the recognition in the meantime. Keep up the innovation, keep up the partnership strategies, and continue to build those tertiary quaternary services that we're all going to need.
That's perfect. Nice bow. Well, we have an event coming up tailored to AMCs. A lot of this must be the topics, the focus, the agenda for the event.
So glad you mentioned that. This is an event we've been planning for a year, and it was going to be physical. MD Anderson had very graciously offered to co-host our event in Houston. However, we're not actually making a destination this year. We're going to be having it virtually. And the topic of our AMC Summit in 2020 will be solving for X, the academic clinical enterprise equation. There are three pieces to this, and to answer each, we're going to be calling in guest speakers from three of those academic centers that often receive a lot of destination travel. Those three individual pieces are, number one, reengineering the clinical enterprise, which will be covered by Michigan Medicine. Drs. Dickey and Flanders will be talking about how their capacity constraints can be somewhat decanted by partnerships in the community and also virtual health outreach. Number two, reimagining engagement, a topic covered by Dr. Clark Otley at Mayo Clinic. He's the chief medical officer for the Mayo Clinic platform. We were just talking about those digital platforms, and Mayo Clinics has perhaps the most famous of AMCs. It has an advanced care at home. Some would call that a hospital at home sort of component. And then also components that facilitate research in terms of a data sandbox and also virtual types of diagnostic activity. Some would call that maybe precision medicine. And then finally, the third topic is from our co-host and sponsor, MD Anderson. It's on revitalizing organizational resiliency. The talk will be given by Dr. Peter Pisters, President, University of Texas MD Anderson Cancer Center. And that'll be on environmental risk assessment, something that's really critical as we move forward with strategic planning, is we change and shift from a longer term strategic planning outlook to a short term, from 5 years or 10 years even, to maybe 3 months. And thinking about what those sorts of environmental scenario plans are that could impinge upon the brand risk is going to be top of mind for that talk. And just really excited to have 4 brilliant speakers from 3 brilliant organizations at our event. So certainly, if you're an SG2 member, stay tuned.
Thanks for that. I can see how those topics really fit with what you both covered today. So thanks for joining SG2 Perspective. And thanks, of course, to our listeners. Please subscribe or follow if you want to hear more. I, as always, like to recommend another Vizient podcast, The Modern Practice. It's on Vizient's Medical Leadership channel, provides a clinical perspective into current issues affecting healthcare today. Thanks, everyone. Have a great one. Stay safe.
Thanks, Trevor.
This has been another great episode of SG2 Perspectives, where industry experts and SG2 thought leaders explore the drivers of tomorrow's healthcare strategies to inform today's decision makers. Contact us anytime by sending an email to sg2perspectives@sg2.com. We'd love to hear from you. SG2 revolutionized healthcare demand forecasting with the Impact of Change forecast, and today we're the industry's premier strategy advisory firm. To learn more, visit sg2.com. Thanks so much for listening, and we'll see you again soon.